Good afternoon, everyone. Special time, but same day, Friday. And it's really, really good to be with you for SADS Live number 106, the first Friday of December. And I'm just excited to see what questions you're going to have bring my way to stimulate. I'm already stimulated today. We've had an incredible day here down in Marco Island, Florida for Mayo Clinic's 6th genetic cardiology course, where we've been trying for the last 8 years. We missed a year to educate cardiologists, pediatric and adult, heart rhythm specialists, genetic counselors, geneticists, internists about genetic heart disease and improve their fluency with respect to genetic heart conditions like our SADS conditions of long QT syndrome and CPVT, so that if you're seeing a physician, there's a better chance that there is better competence and confidence with respect to your condition. So that's where I'm at. This is day 2 that we just wrapped up. Tomorrow's the final day down here for our 6th course. And so that's why we had to shift the time. So if you were wondering. And then if you're wondering and you're brand new, and this is the first time you've joined us at SADS Live, SADS is the Sudden Arrhythmia Death Syndrome Foundation, where we are the largest nonprofit advocacy organization dedicated to families with SADS-associated conditions like long QT syndrome, CPVT, Brugada, ARVC, and so forth, where our goal, our mission is to stop SADS, not stop our organization, but stop any tragedies from occurring so that you may be able to live and thrive despite your genetic heart condition. That's what we're about. What I'm about is the privilege of serving as the president of the board of the SADS Foundation for many years now. So I'm Mike Ackerman, in case you didn't know, genetic cardiologist at Mayo Clinic and director of Mayo Clinic's Winland Smith Rice Genetic Heart Rhythm Clinic and the complementary Winland Smith Rice Sudden Death Genomics Laboratory. And on behalf of Alice Laura, as we come towards the end of another year, Alice is our CEO of the SADS Foundation. She brings you greetings, as does her team. Aaron, who obviously sets this up so beautifully for me, so I just show up and plug and play. And Marcia and Jan and Anna and the entire team, we're so glad you're choosing to join us from anywhere across the globe. East Coast time, we are 4:30. That means 10:30 in Europe and probably the morning down under. So welcome. Let's see. Oh yeah, Julie. Julie's telling me it is rough duty. It is so rough duty, Julie, that I've spent the entire day in here, indoors, staring outdoors at 81 degrees and sunny. So it's 70 degrees and calm. And at most, I'm going to get a 30-minute power walk outdoors for the entire day. I think that's kind of actually cruel and unusual punishment to be this close to beauty and be stuck indoors, but that's the life. But great to have you with Julie. I love it when I see your name show up, and we're going to dive right in. In 2 weeks, we're wrapping up the year with the latest, greatest, and I'll tell you about that towards the end. But right now, we're focusing on your questions. We just finished here at our course a 2-hour workshop, allowing our attendees to ask a question of a case they've been wrestling with and hear and see how we think through that genetic heart condition and the way to work it up and the role of genetic testing and what to do with the genetic test results. So it's been incredibly stimulated, but your questions always, I love them. And here they are. Alice gave the instructions. Make them short and easy to read. I said the same thing to our attendees today. Make their questions and the way they tell us about their case pithy, the word of the day, pithy, P-I-T-H-Y. So Lasena, if I'm saying your first name right, is getting the first question, and her daughter has type 3 long QT syndrome. The EKG looks normal, telling us the QTC is 450 and looks good. Stress test shows a number. Holter came back high QTC 520 and makes you scared. Our doctor said Holter is not 100% correct. I am so worried. Ascena, I love your question, but don't be worried. I'm not worried at all. If your daughter's diagnosis is correct, that QTC at rest is the most important single number to guide our risk classification. So all things considered, your daughter should be lower risk. I actually don't even turn on the QTC feature on the 24-hour Holter because it is so misinformative and misleading, and it doesn't give me anything that helps me decide whether I need to intensify therapy or not. So I personally would not worry about that Holter number at all. So I agree with your doctor 100%. Lauren's wondering about 20 milligrams normal of Nadolol. Is that a normal dose for long QT? Have never been stress test after starting beta blocker. Her QT is always around 500. It's so important, isn't it, in this day of personalized medicine to too hot, too cold, just right. And what I mean by that is when I take care of my patients with long QT, I am trying to dial in the right medicine at the right dose for the right time of their life to keep everything right. And I like Nadolol. As you know, it is my favorite beta blocker. It's all of the long QT experts throughout the world. It's their favorite beta blocker experientially. Second place is propranolol. And there's some settings where I actually like propranolol better. So for example, I tend to use propranolol more for LQT3. I use Nadolol preferably exclusively for LQT1. So I kind of want to know, Lauren, what's your genetic type? You should be stress tested after being on a beta blocker. We do that routinely. And then the 20 milligrams, it depends. Is this a baby, toddler, teenager, adult? If you are an adult, 20 milligrams is a light dose, but that light dose may be all that you need. And so again, I would be looking at several features. Do I have patients on 20 milligrams of Nadolol? Absolutely. Are they high risk at patients? Absolutely not. So if I thought their risk of long QT was in a middle, medium to spicy category, I would not be confident in that dose in an adult patient. Now, if that's a baby, that's a strong dose. So everything depends, and hope that helps you give a context. Corey, this is special. Hi, Corey. I think it's the first time I've seen you on, and is asking, does anxiety cause you to believe PVCs or extra heartbeats are there even when they're not? Oh, that's so good. One of the topics of 2023 and speakers that I'm going to have is Dr. Samuel Sears, psychologist, and I love the way he thinks about the way cardiac conditions and mental health and resiliency and well-being. And we will have a lot to unpack during that program. And I promise I'm going to work hard to get that first of the year early in the calendar year, as in the first 6 months. Okay. Now, anxiety is part of life, even though, one of my favorite life verses is be anxious for nothing, but in everything by prayer and supplication, let your requests be made known unto God. And the peace of God, which passes all human understanding, will keep your heart and your mind in Christ Jesus. I love that. That centers me, that anchors me. But we also have anxiety. Perfect love casts out all fear, all anxiety. But we have reason when we have health issues to be anxious. Some of us are just anxious anyway. And, the heart and the brain connection is incredibly profound. And when you have a heart condition where you have awareness that can cause danger rhythms and potentially do something nasty or try to do something nasty, it's no surprise that there becomes a brain-heart connection. See how intersected they get? And it can grab you, the brain. And I work with lots of patients to undo the snake hold. And I always get confused. Is it a cobra or a python that wraps around its prey? I think it's a python. And it used the analogy that's what the brain, the subconsciousness does. The anxiety center is it just wraps around in the chokehold. And we need strategies Some of us do well with our strategy. Some of us do poorly. And yes, it is so wild what the brain is able to do. It can make you believe 1000% that your heart is skipping beats, beating abnormal, when your heart is beating perfectly normal. And so we work towards that. And we're working with a counselor and counseling, and sometimes breathing strategies and centeredness and mindfulness, praying, and sometimes medications. And we'll have a program not only on mental health and well-being in patients with SADS conditions, but also the use of anxiety medications when necessary, even for somebody with long QT syndrome, when that medicine might find its way on the do not take QT drug list. Thanks a lot, Corey, for the question, and give a big hello to your mom and dad. Scott, when someone presents to you with an incidental finding, that means it just happened, it's not like I was looking for it, and it's called a VUS, variant of uncertain significance, in SCN5A, that's the gene, where a true mutation truly can cause LQT3, or a true mutation can truly cause Brugada, but now we don't know if this is a true mutation. There's no family history, Scott's saying, and the ECGs are normal. Do I generally move to more invasive testing like an EP or a drug challenge? So I love the question, Scott, because what we're trying to get ourselves convinced is, does this VUS matter at all? Is it a nothing burger and it should be demoted to benign and never talk about it again? Or is it a VUS because the company was stuck labeling it in that level of ambiguity, and we need to work to get it unstuck because there's features of it that are tilted towards pointing to potentially pathogenic, either pathogenic towards long QT3 or pathogenic towards Brugada. So what would I do with that? I'd look at the family history. If there's nothing, ECG normal in everybody, no hint of QT, no hint of Brugada, and then I would look at the VUS itself and say, why did they call it a VUS? Where is it located in the gene encoded sodium channel? Is it encoded into territory neighboring, no doubt about it, mutations? Or is it hovering around the area of the protein that we already know is full of so-called background noise? So if it's nothing and it's in that area of real estate that I don't care about that much, I'm going to try to get this ended, as in stop. If I'm suspicious after that assessment, I might move the leads up your chest to see if it brings out the Brugada pattern. But I seldom do the drug challenge when I'm underwhelmed by the VUS. I'm okay with it. We have the little disadvantage in North America, United States, where we only get to use flecainide and procainamide as our drug challenge to try to bring out a Brugada pattern, whereas in Europe and other parts of the world, they can use ajmaline, which is a better chemical to better bring out the pattern if it's there. And so I don't do drug challenges that often overall. Third, next question, how can a child with CPVT that has had a sudden cardiac arrest before diagnosis be treated safely for ADHD? Great question. Answer easily. I know it's out there, but there's a lot of things out there that are just not accurate, just not true. We have spent 20 years taking our patients who have long QT syndrome, CPVT, and concomitant ADHD. It doesn't cause each other. Remember, 7 to 10% of all first world children, if you will, in first world countries have ADHD. That means 7 to 10% of all long QT families, all CPVT families, get to have one or more child in that family who has ADHD, whether or not they have the long QT or the CPVT. And why is ADHD on the do not treat with stimulants list? And it's because stimulants act sort of like adrenaline, and adrenaline is the evil chemical for LQT1 in particular and CPVT as well. So the notion has been, sorry, can't have those drugs. And I think we made a major mistake over the last 2 decades of taking families and depriving them of effective therapy to get their ADHD under control so that they can live and thrive. And we've been doing that, and we've shown over and over again that the irritating effect of ADHD stimulant therapy on the heart of somebody with CPVT or long QT is almost zero. Can never say zero, but it is really, really low risk. And I think we need to do a better job from moving from the paralysis of fear paralysis, to confident, intentional action to treat the whole person. Thanks for that question. Lauren's asking, a parent has long QT syndrome. The genetics came back negative. Kids got EKGs and they're normal. Would I ever put the kids on the beta blockers as a precaution if the parent has long QT syndrome? Oh, Lauren, great. You guys are as incredible as our workshop today. So here's what I would do first. For that parent is said to have long QT syndrome and the genetic test has come back negative, somebody needs to stare at that parent again, closely, carefully, and decide, are we really still comfortable calling him or her long QT? Because a negative genetic test by itself, all by itself, rules out 80 to 90% of long QT syndrome. Now, if I look at you, the parent, and I see, I don't like your QT, I don't like your story, I don't like all of this, you are long QT syndrome. Well, then I don't care if the test has come back negative. You still are long QT syndrome. But many, many times, that person who was called long QT syndrome, if you look back at it, the strength of evidence would never prompt a guilty verdict. And at the Supreme Court, it would get turned over and thrown out as no evidence or not enough evidence. So go back, somebody stare at you. And now if you are it, and that's fine, gene negative, long QT, but your children have normal ECGs. No, I can never say never. I basically never would put that normal ECG child on a preemptive prophylactic beta blocker just because of that scenario. Beta blockers are just not free of charge. There are potential side effects. And if I can't even make a diagnosis from any test, then I would not just throw in beta blocker anyway. Kelly is asking thoughts on the Medtronic SICD. Any ideas when it will be available in the United States? Oh, good question, Kelly. So a couple things. SICD stands for subcutaneous internal cardioverter defibrillator. As we know, right, the standard defibrillator, I'll show, well, this is my car keys, but it gets installed underneath the clavicle, lead tunnels into the heart. That's the standard transvenous endocardial ICD system. Then we have the SICD where the generator is bigger. So instead of this size, right? Oh, it's not quite as big as my phone, but it's pretty big, maybe more like this. How about this speaker? And it goes right here in your side, and the lead then tunnels underneath and up. And that is called the SICD, and it's approved in the United States from the company Boston Scientific's SICD device. I think Kelly's referring to what will then be the newer generation or the newest generation. And there, I'm not actually sure if they're using SICD as the abbreviation or a different one where that version of the device is going underneath the sternum, the breastbone. And so the lead is running up here and the generator gets placed somewhere else. And Mayo Clinic actually, if I'm thinking of the device you're talking about, My chair, Dr. Paul Friedman, published the paper, senior author in New England Journal of Medicine, with the results from that device. So it's making its way. It looks very encouraging as a new way to potentially implant a device or a new configuration. And so I don't know the when. It looks like everything's on track, meaning I haven't seen anything to derail an approval process once they do all of the necessary work. So I don't know. If I were to guess, I would say that likely will be an FDA approved gadget within 2 years, but don't hold me on that one because I don't have firsthand knowledge of any sort on that. And I get, okay, great question from Anjuli. I don't understand the differences between Brugada type 1, type 2. Could I explain? I'd happy to. So in our families, so there's two different words that I want us to know. Brugada ECG pattern, that's a look on a 12-lead electrocardiogram, and somebody who has Brugada syndrome. That is a disease, a syndrome that's potentially arrhythmic, where its hallmark signature is a Brugada ECG pattern, and a specific one. So a type 1 pattern has a particular look and feel to it, and it has different descriptors to it that your heart rhythm specialist, your heart electrician, he or she is looking at. And if somebody owns that type 1 Brugada ECG pattern, that allows me to start thinking about, could this be Brugada syndrome? So that pattern starts the possibility of the discussion. The non-specific patterns start nothing. So those non-specific patterns are called a type 2 pattern. That has a different look on the ECG. And that pattern getting connected to Brugada syndrome is really, really weak unless the owner of that non-specific pattern converts to the type 1 pattern when you move the leads up the chest. And with that maneuver with the 12-lead ECG leads, now the pattern became more concerning for the possibility of the syndrome. Or somebody mentioned drug challenge. If somebody with a non-specific pattern and a story that was concerning might be somebody who would get Ajmaline in Europe or flecainide or procainamide in the United States. And if with the drug converted the non-specific type 2 pattern to a more concerning type 1 pattern, then again, the possibility of Brugada syndrome would get entertained. And yes, we can have an amen. So thank you, Amy, for that. And a question from Christian, is Paxlovid safe for long QT patients with COVID? And how concerned should one be about the drug-drug interaction between Paxlovid and Nadolol? Great question. I think that drug-drug interaction, I'm not concerned about it. I'm also not concerned about Paxlovid at all in terms of potential QT danger. So bottom line, if one of my long QT patients treated with Nadolol gets COVID-19, and that COVID-19 needs to be treated with a medicine like Paxlovid, doesn't change my concern meter at all. We proceed, we treat the COVID-19 with Paxlovid, and I'm not worried of it agitating the long QT syndrome, and I'm not worried about it changing the level of protection or the drug-drug effect of the Nadolol. But really, really important question and a great one. Andrew, as a type 1 Brugada, again, so that's where I think we sometimes get confused, type 1 Brugada. So that could be either I own a type 1 Brugada ECG pattern, or I have a mutation in the SCN5A gene for which I have Brugada syndrome subtype 1, which is also called SCN5A mediated Brugada syndrome. So we haven't been very clear in the literature to distinguish those. I think they're actually important. So when I refer to somebody, I refer to their ECG as does it or does it not show the type 1 Brugada ECG pattern. And then if they have Brugada syndrome due to a loss of function mutations in the SCN5A encoded NAV 1.5 sodium channel, that person has Brugada syndrome 1. Just like somebody who has a mutation in the sodium channel that causes long QT syndrome, that person has long QT syndrome 3 or LQT3. See the difference? But in either case, Andrew's wondering that the EP wants to wait and see for a defibrillator. A history of present illness, a multiple asystole, that means the heart stops for a bit. Syncope, SCN5A, so he has Brugada syndrome, ECG pattern, and paternal sudden cardiac death. How do I handle the anxiety without security of a defibrillator? That's such a good question, because a couple things I'd say: the fact that there's been tragedy in your family, tragic, yes, the paternal side, but that doesn't change my forecast for you. So in other diseases, it would, but not in Brugada syndrome. But in your case, you have syncope. That's a little concerning. The diagnosis doesn't sound difficult, and you have had events. So I think it's really having one of those shared decision-making discussions with your EP as to why are you waiting? Is it best to wait? Are you coping okay with waiting? Or does somebody with syncope and Brugada syndrome, would it be as acceptable to add protection with an internal defibrillator? That's a tough one. And I think if you're not at peace with this recommendation and having anxiety, you need to discuss this with your primary electrophysiologist, because maybe the balance of power would be shifting for that kind of a person, whereby we might need to come up with another treatment strategy. Let's see. Wait, I just believe. Okay, I think that was a. Oh, this was tough because it got separated by two things. It's believed, thanks Sharon, that you might have congenital long QT. We're still waiting for the genetic test result. You're 46, so you're young, and have never had a symptom before now, and you're perimenopausal. Is this common? I fainted during exercise while on sertraline, which is also trade name Zoloft, one of the anti-anxiety, antidepressant medications, and have had problems since stopping the meds. I think it's going to take some homework there. It's a great case, Sharon. I think just from what you shared, I think people should be very intense in their detective work to figure out, do we even think you have a QT issue? Why do we think you fainted? What does your QTC show? And I would be getting those more often initially to see what's your number, because just at the story, it's not jumping out sort of long QT. Of course, I'm not giving medical advice. I'm just reacting to the story as the initial thumbnail sketch. So I think there's work to do to get things figured out. Lucen is asking that she sees most cases with type 3 take mixilotine and beta. We are only on beta. Thank you. Can't wait for our appointment. Well, I can't wait to meet you. It will be my privilege. No, I think there are many, many patients with type 3 long QT syndrome, so LQT3, where they are on just a beta blocker. And that may be all the person needs. I have many patients who are on beta blocker only. Arthur Wilde, dear friend, colleague, director of the genetic heart program in Amsterdam, published the paper showing that beta blockers are effective in LQT3. It used to have this rap on it that beta blockers weren't effective, protective, and were potentially dangerous. Nope. Turns out to not be the case. They're protective. They may not be as good in LQT3 overall as in LQT1. So a risky, twitchy LQT3 person, would I be on beta blocker only? No. Or would a low risk LQT3 patient that I'm deeming low risk by all of the assessment, might they be on a beta blocker all by itself? Absolutely. Now, do I like mixilotine for LQT3? I do. I also like it for LQT2. And it doesn't always work in LQT2, but it clearly has an effect in this subset. The challenge with mixilotine and why I'm hopeful for a new drug trial that we will be having the company responsible for that new drug in development for long QT syndrome called Thrive Therapeutics. Join us in January and tell us, what does that world of drug development look like, and what's the timetable, and what happens, and how does it happen? Is that could be, if it all works out, if a alternative to mixilotine, because we're stuck with mixilotine with 3 times a day dosing, and you can't sugarcoat that. Anything that has to be taken 3 times a day is a bummer. And so I'd love to have a mixilotine alternative in the future. And again, I can't wait to see you. Christina is asking about LQT2 in sports. You have a son, 16. I love that. He is going well with it until our doctor doesn't let us do sports. Yeah. And we are from Greece. Well, I wish you were from close enough to get to me, because I think over the last 20, 30 years, we have damaged more young people with the if in doubt, kick them out posture. And I've lectured on this regularly, often, anybody who is interested, where we take people who are at incredibly low risk, we have them well treated for what we've discovered they own, but then we tell them, but oh, by the way, don't get off the sofa, the couch, don't do anything more than walk to the bus. Ridiculous. Overall, ridiculous. We have shown over and over again now for 20 years that we can safely and confidently enable a well-studied, well-treated, well-counseled person with long QT to stay in the game of life. And I refuse to embrace the old way of shutting the engine down and saying, yeah, just get used to it. Sorry, it kind of stinks, but you don't get to do anything. No, my view is I want my patient, within reason, to believe that he or she can become anything and everything that their skill set, their discipline, their determination, their drive, their giftedness takes them to be. Now, are there some things that are takeaways? Yeah. I can't get your son to the single engine cockpit to be a Top Gun pilot, no matter what. That's a no-go. I probably can't let you do arc welding if you own an internal defibrillator. Might bother the internal defibrillator. Challenging to enable your son or your daughter to serve in the military if it's already known you have long QT. Used to be never. Now I just say challenging, because we've been successful for the young men and women who wanted to serve their respective country to be able to do that. So the point is, in my world with my long QT families, I want them to believe that the world is their oyster and they can have almost anything and everything that their desire, drive, giftedness will take them. So may need to work to find somebody who embraces that vision, or share and give that doctor a chance to come to that realization that that is a different way of thinking about it. Ryan's asking, is there any new research on ways to prevent Brugada syndrome from triggering a faint or a cardiac arrest? I read an article about a full belly or a large meal provoking a Brugada pattern. Oh, good. I love it. You guys are incredibly current about things. And so the question that is relevant is, are there non-medication ways, non-procedure, non-surgery, non-device ways that we could short circuit the Brugada heart or the long QT heart or the CPVT heart from doing the danger rhythm? And slowly we're learning about what some of those irritants are. So we know that, like you just pointed out, a full meal, big meal, can be irritating to the Brugada substrate. And sometimes we tell patients, before your morning ECG, I want you to eat the biggest breakfast you've ever had, because that enhancement of vagal tone might allow the pattern to come out more readily, to see it. We know that fever is Brugada irritating, so we lower fever. We know that alcohol to drunk is Brugada irritating, so we don't get drunk. We know that marijuana and cocaine is a bad idea, probably period. Cocaine for sure. We can have a debate on marijuana. I'm in the camp that thinks it's still probably pointless. Never done it. Haven't inhaled. Haven't even put it close to my mouth. Well, now we know each other. And so, but in Brugada, those toxins, if you will, cocaine and marijuana, are Brugada dangerous. But are there other things, like what if I am cool, calm, and collected? My wiring, my persona, does that make me safer? Maybe. So doing things like, we haven't proven how that breathing efforts and different ways that you can control what's called heart rate variability and other things, why that could give us a defense shield. So more to become down the line about that. They're not great studies yet, but they're starting to happen. Well, we're coming to the top of the hour. And it looks like I'm going to take Shelley's as the final one. And when we get our next question and answer session, we'll pick right back up. So Shelley, you get the last one. And she's wondering, how important is it to be on medication for long QT2 when 3 months postpartum, and what medications would be more effective? Really great. I love it, Shelley. So long QT2, we and others published 20 years ago that there's a connection with the postpartum phase, so roughly the first 6 to 9 months after giving birth to your child. And so congratulations, first off. This means that you have a little 3-month-old baby. And so congratulations to you and your family. That window of time, that 3, 6, 9 months postpartum, is a window of increased risk for an LQT2 triggered faint, seizure, or tragedy. It's not spooky risk, though. It's higher than it was than when you were 40 weeks pregnant, during the 40 weeks of pregnancy. It's higher than what it was during the 40 weeks before you got pregnancy. But it's not as if this 3-month, 4-month, 5-month mark is spooky. But having said that, I respect it so much that I would want to know, what do I think about your LQT2 profile right now? How easy is it to make the diagnosis just from staring at your ECG? How long is your QTC? If it is easy to make the diagnosis, then that person, whether that person is 3 months postpartum or 3 months pregnant, when I can make the diagnosis easily from staring at the electrocardiogram, that person almost always needs to be treated. So treatment, whether you're postpartum or pregnant, the treatment would be beta blocker and Nadolol. And I'm not worried about a little Nadolol getting through the breast milk into your 3-month-old baby. We need to make sure that you are treated properly. So I would urge you to make sure you have an appointment in the very near future, if you are on no therapy, for somebody to say, oh yeah, there's a reason you're on no therapy. And that only the reason that could possibly be is, yes, you have LQT2, but your ECG over and over and over again is completely normal. Well, then you have something called concealed LQT2, and that individual, the postpartum window that might increase its risk, might be increasing it from basically nothing to basically still nothing, maybe a little bit more than nothing. See what I mean? But if you have LQT2 and I can diagnose you with LQT2 without the genetic test, that young woman, whether 1 month, 2 month, 3 month postpartum, or 1 month, 2 month, 3 month pregnant, or just a 15-year-old with no plans of getting pregnant yet, that person needs to be treated. So I wish you well with that. Well, thanks for a great 40 minutes together. I hope you enjoy these sessions as much as I do. Come join us at the regular time again, 1:20 p.m. Central Standard Time, in now just under 2 weeks. So December 16. And I'm going to be joined by my former trainee, dear friend and colleague, Dr. Andrew Landstrom, who's going to be sharing with us, and we're going to review together the 2022 highlight reel of the 5 most significant advances in our field with your conditions from his perspective. And we'll have a fun conversation about that. Until you join us back in 2 weeks, go to our website, www.sads.org. And as we come on this season of Hanukkah and Christmas or holiday, whatever you refer to, hit that button in that top right corner called Donate Now, and give a gesture of gratitude and thanksgiving for what the folks at the SADS Foundation, Alice and Marcia and Jan and Aaron and Anna and the entire team have been doing as the program, the SADS Foundation, is yours. It is dedicated to you, for you. Genevieve, I didn't mention. And say thank you as we come to end of year. And I am particularly thankful for you and each of you, and that you chose to spend these 40 minutes with us today. So best to you, blessings, and I can't wait to join you again in 2 weeks with Dr. Andrew Landstrom for SADS Live 107. Till next time, blessings, everyone.